Here enters another fundamental point that will guide the entire treatment philosophy of this course: the hierarchy of what truly determines the success and longevity of any work you perform. In order of impact, from most relevant to least relevant: first, the patient's context, their lifestyle, systemic diagnosis, follow-up, and adherence to treatment. Second, the balance of the stomatognathing system, occlusal factors, muscular function, temporomandibular joint health. Third, tooth diagnosis, the quantity and quality of remaining structure. Fourth, restorative technique, the method and strategy used. And finally, dental material, brand, model, chemical composition. This means that the material you choose, which is frequently the center of discussions in courses and congresses, is actually the factor with the least impact in this hierarchy. Not because material does not matter, it does, but because the best material on the market means nothing in a patient whose etiological factors remain active, whose occlusion remains dysregulated, and who will continue destroying what you restored the same way they destroyed the original tooth. And here is a fact that needs to remain clear: dentistry still does not possess materials capable of fully biomimicking dental and periodontal structures to the point of resisting POAS indefinitely. Composite resin, ceramics, zirconia, all are materials with excellent properties, but none of them possess the structural complexity of natural enamel, natural dentin, cementum, or the periodontal ligament. None of them were designed to tolerate, for decades, the forces generated by a patient with active bruxism, uncontrolled reflux, and fragmented sleep. Completing restorative work, even when technically perfect, does not guarantee long-term success if the factors responsible for the destruction remain present and active. The consequences of this affect everyone: the patient, who will redo treatments, lose teeth, and accumulate frustration; the dentist, who will lose time, compromise reputation, and experience the exhaustion of working hard only to achieve short-term results. Patient control, maintenance, continuous follow-up, periodic reassessment of etiological factors is not a treatment detail. It is a central part of treatment itself. And it is also important to make something clear: the patient has the right to choose between comprehensive disease treatment or simple monitoring if symptoms are not limiting at that moment. Both approaches are legitimate as long as the patient is fully informed about what each choice means in terms of progression, risk, and future cost. Your role is to guarantee that this choice is made with complete understanding, not because of lack of information or incomplete